So we all know that kidney transplant patients are at high risk of developing severe COVID because of their poor immune status and lot of associated comorbidities. And also the presentation is atypical. They can present with mild upper respiratory infection to severe acute respiratory distress syndrome. And in such patients, we have to aim to reduce the risk of viral transmission because they have higher viral loads and they shed lot of virus loads to others. Uh, to plan management, we categorize these patients into three: mild transplant recipients having mild symptoms including fever, cough, without hypoxia and dyspnea, and uncomplicated upper respiratory tract infection. Moderate COVID when patient has clinical pneumonia with mild dyspnea, hypoxia, SpO2 of less than 94%, and respiratory rate of 24 to 30, and severe COVID when there are signs of clinical pneumonia with any one of these three, that is respiratory rate more than 30, severe respiratory distress, and SpO2 less than 90 on room air. In a multi-center cohort study of 250 patients with COVID from 13 centers across India, which was probably the largest study published in world literature by Dr. Kutte and Dr. Anil Bhalla et al., we found that fever was seen only in 88% cases, and 3/4 of them had cough, and 50% had expectoration, while other symptoms were seen in 20 to 25% of patients, and 6% were asymptomatic. 60% had mild pneumonia, 20% moderate disease, and 14% had severe COVID pneumonia. Overall patient mortality was 11.6%, and those who were hospitalized, mortality was 14.5%, and patients in ICU had a mortality of 47%, and those who were on mechanical ventilation, 97% succumbed to the illness. And these studies are published last year, a multi-center study from Spain by Alexandre Fava, in which they found that 104 transplant patients, which were from multi-centers in Spain, and they found that 27% died, 55% had ARDS, and risk factors included older age, obesity, ARDS at presentation, and high LDH levels at presentation. And similar findings, risk factors were noted in this study published by Dr. Kutte and Dr. Bhalla. And in another UK transplant registry, which was reported last year in May 20, and they found out of more than 47,000 solid organ transplant recipients, 597, that is 1.3%, tested positive for COVID, and 26% of them died. And on wait list, there were more than 5,000 patients, and 3% tested positive, and mortality was 10% amongst those. But during that period, around 1,000 transplants were done, 4% positivity rate, and mortality was less than 0.8%. In a study published by our own group last year, we found that 50% of our admitted patients had mild disease, 25% had a moderate COVID, and 25% had severe illness. And our mortality, which we found in our admitted patient, was 25%. In a recent publication from France, out of 1,200 transplant patients, they found around 5% patient they developed COVID, and mortality in non-COVID patient was just 1%, while those who had COVID, 24% died. So this was the severity of COVID, just to highlight that how COVID in transplant patients can be severe and high mortality is noticed. And now I'll discuss this topic in three heads: investigations, management of immunosuppression, and treatment of COVID in transplant recipients. And as you investigate febrile illness in transplant patient, you go for those investigations. And plus we do inflammatory markers, baseline, and then time to time we can repeat ferritin, CRP, D dimers, and IL-6. But it is a set protocol when you should do, not so frequently. It depends upon the patient's clinical situation. And it has been seen that though these markers have been associated with severe disease, but they are not really related to prognostication of the disease. Chest X-ray is the routine investigation which shows ground glass opacities, consolidation, which are more common in both lower zones, and they are peripheral. And CT scan should be reserved for those patients who are on oxygen support and they have evidence of pneumonia. They have ground glass opacities with mixed consolidation adjoining the pleura, and there is air bronchogram, intralobular thickening of the septum, and this is to show you a normal CT picture. Patients who have pulmonary edema, here you find that these ground glass appearance is perihilar, while in a COVID patient, these are peripheral, air bronchogram, there is thickening of the septa. And this is a late sequelae of COVID. You can see the fibrosis and a ground glassing and even mediastinal emphysemas. Now coming to the treatment, if you look at the pathogenesis of the disease, there are two processes. Early in the clinical course, disease is primarily run by the replication of the virus. So antiviral therapies would have the greatest effect in early stage of the disease, while later in the clinical course, disease appears to have to be due to dysregulated immune response, which leads to tissue damage. And here there is a role of immunosuppressive and anti-inflammatory therapies. So how should I manage immunosuppression in a kidney transplant patient? Last year in May, there was a very good paper. It was guideline from ERA, EDTA, Descartes expert group. And I'll just highlight a case which we saw last month, a 40-year-old male who had a kidney transplant 2 years ago, wife being donor, 6 antigen mismatch, had induction with ATG on triple immunosuppression. And his renal functions were normal till 2nd of April 21. His wife developed COVID, was quarantined. Recipient on 17th was RT-PCR negative, but 4 days later, he developed fever, mild cough, and diarrhea, but there was no dyspnea, loss of taste or smell. His COVID RT-PCR was positive at this time, but his heart rate, respiratory rate, and oxygen saturation were normal, and he was managed on OPD basis with reduction in dose of MMF. And along with doxycycline, vitamin C, D, zinc, and ivermectin. However, on day 8, he came to us with fever, worsening cough, and a hypoxia, and there was increase in respiratory rate. He was admitted, started on supplemental oxygen, remdesivir, and convalescent plasma. He recovered. And there is another patient who had a similar initial course but presented late because he could not come at the right time due to lockdown. And however, he was in contact with the transplant physician, and his MMF was stopped, and Vicelone was increased on phone at the 5th day of illness. When he came on 10th day of illness, he was breathless, heart rate 110, respiratory rate 28, and oxygen saturation 92 to 93%. Was put on high flow oxygen, remdesivir, and convalescent plasma given, and his immunosuppression was stopped, given dexamethasone. Tocilizumab was not given because IL-6 was not meeting the criteria, and there was suspicion of sepsis and ALC were low. So now coming to the principles of management. As a first step, we reduce or withhold the antimetabolites. Generally, we continue with CNIs because they inhibit IL-6 and IL-1 pathways, which are responsible for cytokine storms. And need of glucocorticoids is evaluated on case-to-case basis because glucocorticoid use is associated with prolonged viral shedding and at times poor outcome, as was highlighted by the earlier speaker. Now, ERA Descartes working group guidelines for treatment. Transplants who are 3 to 6 months or beyond, asymptomatic, non-COVID, no preemptive or proactive treatment required. Those who are asymptomatic, positive RT-PCR, consider stopping or reducing MMF. Look at the risk factors like age more than 70, comorbidities, hypertension, diabetes, or overweight, vintage of transplant, prior history of rejection, or use of depleting agents, or renal functions which are less than 30 mil per minute, and severity or worsening of labs. So these are high-risk groups, and I come to the next management level, mild pneumonia with SpO2 more than 95%. Those who are on triple immunosuppression, you stop antimetabolites, continue with CNIs and steroids. Dual therapy, including steroids, continue with the same medication. However, dual therapy, steroid-free, if they are getting CNIs plus MPA, change MPA to low-dose steroids. CNI plus mTOR, consider replacing mTOR inhibitors with low-dose steroids. Or if they are on MPA and mTOR inhibitors, consider replacing any of the two with steroids. If person is not having clear improvement over next 3 to 5 days, consider reducing the dose of CNI to a level of 3 to 5 nanogram per mil, and cautiously restart previous immunosuppression 3 to 7 days after clearing of the symptoms. And patients who have mild disease but oxygen saturation less than 95%, respiratory rate 25 to 29, and there is a suspect lesion on CT. Those who have high risk, stop MMF and CNI, increase steroid dose to 15 to 25 milligram a day, and cautiously restart CNI after 5 to 10 days of clearing of the symptoms. Those who don't have high risk factors just stop MMF and reduce CNI levels and maintain 3 to 5, or CSA levels maintain between 50 to 75. Steroids continue in the same dose and cautiously restart the immunosuppression after 5 to 7 days of clearing of the symptoms. If you are planning antiviral treatment, then stop CNIs. But now those antivirals are not recommended. So with remdesivir, there is no problem because there is no drug-to-drug interaction. Those who have severe disease, severe COVID pneumonia, discontinue all immunosuppressive medicines, increase steroids to 15 to 25 milligram per day or higher according to the local practice. And consider continuing with low dose CNIs in patients who are at high risk of rejection. Cautiously restart previous immunosuppression after 5 to 15 days after recovery. So these are the latest INH guidelines which appeared in April 21st of this year. So home management is encouraged because it has been seen that no therapy has been proven to be beneficial in outpatient COVID patients with mild to moderate COVID who are not at high risk. And supportive care and symptomatic management to outpatients with COVID-19 reduce the risk of COVID transmission to others by telemedicine, and patients should be advised about when to seek in-person evaluation. When there is mild to moderate disease in outpatients who are at low risk of disease progression and they don't have potential for clinical benefit, just supportive care. But outpatients with mild to moderate disease who are at high risk, then you should use these drugs, bamlanivimab and atezolizumab combination, or recently casirivimab plus imdevimab has been released and for emergency use administration by US FDA, and it is available in India now. And this is based on BLAZE-1 trial where they found that bamlanivimab and atezolizumab combination in more than 1,000 patients which were compared with the standard of care, they found that there was 5% absolute and 70% relative reduction in hospitalization or death. But there they used a 2,800 milligram dose, but they have found that in clinical use, the doses which are mentioned, 700 plus 1,400 milligram, is having the equivalent response rate. And casirivimab and imdevimab, the clinical trial is going on. Results are not yet published, but electronic results, they favor that 3.3% absolute and 71% relative reduction in hospitalization and death. And treatment should be started as soon as possible when you get the positive COVID test, and it should be started within 10 days of the symptom. Now, coming to patients who are hospitalized but does not require supplemental oxygen. So there is insufficient data to recommend the use of remdesivir, but for patients who are at high risk, like transplant patients, use of remdesivir may be appropriate. This is the panel recommendation by INH. NIH group. Now coming to patients who are hospitalized and requires supplemental oxygen. Use one of the following options: remdesivir for patients who require minimal oxygen support, dexamethasone plus remdesivir when the oxygen support is increasing or demand is increasing, and dexamethasone when combination therapy cannot be used if the remdesivir is not available. In rare circumstances when you cannot use steroids, then baricitinib and remdesivir can be used in the dose of 4 milligram per day for 14 days. And the baricitinib should not be used alone, and it is contraindicated if GFR is less than 30 ml per minute. For the more severe disease, hospitalized patients requiring oxygen delivery through a high flow device or who are on non-invasive ventilation, use one of the following options: dexamethasone, where there is a strong evidence. Dr. Sabrimala has discussed earlier, so I need not discuss all those trials. So dexamethasone plus remdesivir, there is moderate degree of evidence. And for patients who are recently hospitalized with increasing oxygen requirement and they have systemic inflammation, add tocilizumab as to one of the two options above. Now coming to the severest forms of patients who are hospitalized and require invasive mechanical ventilation or ECMO, dexamethasone. For patients who are within 24 hours of admission and they are showing severe systemic inflammation, or then the dexamethasone plus tocilizumab. So as mentioned by the previous speaker, the guidelines by AIMS and ICMR published on 22nd of April, they are also recommending the similar treatment. Now coming to anticoagulation. So the NIH guidelines are patients who are receiving anticoagulants or antiplatelet therapies for their baseline condition, you should continue these medicines. Suppose they are taking it for after CABG or PTCA, they should continue with this thing. But for prophylaxis of venous thromboembolism, for non-hospitalized patients, these are not recommended. But if patient is hospitalized, then for prevention of venous thromboembolism, they can be given in non-pregnant adults. So some words about the convalescent plasma. There had been a lot of hype about convalescent plasma, but recently ICMR, Government of India, has disbanded the use of the plasma. There has been evidence which was in favor, and now very large studies have shown that it is not of much use. Coming to NEGM publication on March 18, which involved 3,000 odd patients, and 2/3 of them were not on mechanical ventilation. They found that there was decrease in 30-day mortality after one dose of convalescent plasma with high antibody. That was a reduction by 22%. But if they were given low antibody titer plasma, the mortality reduction was not good. And in another observational study, ICU patient mortality in ICU patient was low, 25% versus 33% who received standard of care, and the benefit was more in older patients who were more than 70 years old. In a meta-analysis systemic review by Claassen, he reviewed 10 randomized trials, 20 matched control studies, and in which 2 doses of convalescent plasma was given. They found that those who received plasma had lower mortality as compared to those who received only standard of care. But now coming to the point why these plasma has gone into disrepute, there is a very large meta-analysis by Vanessa, which included 12 RCTs, and there they found that it did not improve the mortality and there was no impact on clinical improvement. And coming to NIH guideline recently published, there is no role of convalescent plasma with the low or high antibody titers. So these days we are talking a lot about the black fungus mucormycosis. And many things are blamed for that: high doses of steroids, contamination through the moisturizers, and very high oxygen flows. We have come across 4 patients in last 2 months who have recovered from COVID and they developed mucormycosis. Case 1, a 30-year-old male had ABO incompatible transplant, pre-sensitization with Ritux. He received basiliximab, had mild COVID 1 month back, treated at home, and he developed some swelling around the eyes and increased lacrimation. He was an educated reading in the papers, and he immediately came from Allahabad, and within 24 hours he was diagnosed and operated, and he is recovering. A case 2, 6-year male diabetic, 8 years post-transplant, had mild COVID, recovered at home. But he developed extensive mucor involving right maxillary, sphenoid, and ethmoid sinuses, and extension into the orbit, debridement and excitation of right eye done. His recovery. But we had 2 patients who, one of them a 38-year-old transplant done 3 years back, had ATG induction. He was admitted outside for moderate COVID, had a partial recovery, came to our hospital, and he had mucor, and he could not survive because he was very sick and died within 7 days. And another patient, 50-year-old, had a severe COVID and developed mucor, and he died within 20 days, and no surgical intervention could be done. So why I have presented these 4 cases? Yeah, you can see that 2 patients had a very mild disease, treated at home, did not require higher doses of steroids or oxygen, but they had mucor. Case 2 and 3 who died, they were sick, came in a sick condition, but again, they had survived. One of them had survived COVID. So what are the factors which are responsible for mucor? It remains to be seen. Because one of our friends, Dr. Alok Chakravarti, who is president of International Microbiologist Association, he had very categorically said that higher doses of steroids or water used for humidification of oxygen is not responsible, because they have tried to grow it in lab under these circumstances, and they have not found that reason to be valid. So what is the reason for mucor? We don't know. So on nasal endoscopy. These are the findings. This is the case who had orbital infection, all the sinuses on the right side involved. You can see extensive necrosis of the inferior turbinate. And this is a first case who had mucor limited only to the maxillary sinus. Thank you for your patient hearing.